Hi, everybody. Welcome to the CRISM Addiction Rounds. We're just going to wait 1 minute for people to log in, and then we'll get started. So I'll just give it another minute here. Okay, good. So I think we're getting into the 70s for attendees, so I'll get started here. Welcome again, everybody. I'm Dr. Mohit Singh. I'm a addiction psychiatrist here in Edmonton, and really happy to be moderating the rounds today. And I'll just do a little bit of housekeeping, and then I'll introduce our speaker, Dr. Crockford, and we'll get started. So. First thing is that, as you may have already noted, we're being recorded and the webinar will be posted on chrismprairies.ca after the talk today. And it is if you do have questions during the session, please use the Q&A feature to send questions to myself, and I'm the moderator. I'll bring them up with Dr. Crockford, and we'll have the last 15 minutes reserved for questions from the audience and discussion that way. The other thing I want to say is, we really value your feedback, and if you could please complete the series evaluation, which you'll receive by email after the session, and completion of the eval will also allow you to receive a certificate of attendance for your record and CME credits. And just a plug for next time, and on December 17th, we have a talk coming up with Dr. David Hodgins on contingency management for substance use disorders. Um, and so without further ado, I'll introduce our speaker today, Dr. David Crockford, who's a professor with the Department of Psychiatry at the University of Calgary, where he's worked for over 27 years as a psychiatrist. And he's the clinical medical director for the Foothills Medical Center Early Psychosis Intervention Program and a consulting psychiatrist at the Foothills Medical Center Addiction Program and Adult Psychosis Program, where he treats patients with concurrent psychiatric and substance use disorder. Dr. Crockford is a diplomat of the Royal College of Physicians and Surgeons, and also holds an area of focused competency in addiction medicine. He's published in addiction psychiatry throughout his career with over 50 peer-reviewed papers, 3 book chapters, 4 editorials, and 14 research letters with over 2,000 citations. And he's the past 2-time chair of the addiction section of Canadian Psychiatry Association. And he's a Distinguished Life Fellow of the American Psychiatry Association and Distinguished Fellow of the Canadian Psychiatry Association. So really honored to have you here, Dave. And I think I can add to your list of accomplishments, avid and amazing golfer as well. So I'll turn it over to you.
Okay, thanks for the kind introduction. So we'll be talking about involuntary treatment, people with substance use disorders. I'd like to start off with the territorial acknowledgement. So I'm presenting from Calgary at and so the University of Calgary is located in the heart of southern Alberta, and I both acknowledge and pay tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, Piikani, and Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Goodstoney First Nations. City of Calgary is also home to the Métis Nation of Alberta, Region 3. I'm particularly conscious of the acknowledgement too when we're talking about involuntary care, just because one of my concerns forefront with involuntary care when it comes to the treatment of substance use disorders is that it might inadvertently over-involve people of Indigenous backgrounds. I'm going to touch on a little bit of the history of that as well as I go through the talk. My disclosures are, so I get paid by the University of Calgary. I'm a full-time academic and I'm on the academic medical health services plan. I also do review panels for the for the mental health review panels. So I sit as a psychiatrist on them, sort of, and the mental health review panels work to uphold the rights of the patient and hold the treatment team to task around it. I'm not affiliated with any political party. I don't have funding from industry. All the images, by the way, that I am using in the talk come from Pixabay, and they're free and they're in the public domain. It's one of the it's a good website if you want to actually find images overall. So the objectives is we're going to go through why involuntary treatment is being looked at, know the current literature for and against it, and recognize potential problems with the proposed compassionate intervention legislation and the provision of involuntary care and what maybe some alternatives could be. So the problem, and certainly as clinicians, that we're all acutely aware of the toxic street drug overdose, the ongoing deaths which are occurring from this. And this tends to be a lot of what our focus comes from as clinicians. But politicians, not only are they interested in that, but they're also acutely aware of the public disorder that substance use and homelessness has particularly become, and the focus of public in that the electorate is becoming increasingly sort of upset around that, and even the most empathetic people are just sort of they're they want something to be different around it. It's not normal, and this has really changed over the last 10 years. It's very disturbing of how we've come to sort of almost view it as normal. And like this image, the reason why I chose it is that you have these people in the background who are just sort of going on with their lives when you have overt despair, and illness, and potentially even people who are near death right beside us. I think about when I gave a talk on involuntary treatment at the CPA. I was going to the hotel before, got off at the Yaletown station, off the SkyTrain, and was walking up and past like a open drug deal. This is 10 o'clock in the morning, going on Davie Street. And then there's a guy lying on the sidewalk who's, inhaling something through a pipe. And then there's another person across the street who's screaming at the top of his lungs, clearly psychotic and acting on his hallucinations. And it was just that after that going along, and it was like it seems kind of unlivable, the whole situation. And so I think this is part of the reason why governments suddenly are wondering about involuntary care. BC has continues to use the Mental Health Act, and they've slightly tweaked it where people with acquired brain injury could be subject to involuntary treatment. BC has the Redfish Center, which has 105 beds out in Burnaby, which is sort of long-term care of people with mental health and addiction around it, but 105 beds to suit the entire province of 5 million people. Manitoba has just introduced legislation, Bill 48, where people can be detained in a non-medical facility for up to 72 hours, primarily focusing on methamphetamine. They do have to be assessed by somebody who has some medical credentials, but it's one of these things where it's long enough to actually cause real problems with people getting into serious withdrawal and other medical issues, but too short to likely be of any kind of meaningful difference to set up sort of treatment planning and the like. Ontario is debating involuntary treatment for those who are in jail. I think the problem that Ontario is quickly going to run into with this idea is that 75% of people in jail in Ontario have not actually, they're there on charges, but haven't actually been to court. And so mandating people to go into treatment who haven't even been criminally convicted is going to be highly problematic. And then in Alberta, we got Bill 53, which is the Compassionate Intervention Act, which I'll talk about as the later on. So the rationale often tends to come from highly emotionally charged and morally charged reasons. We have to do something. People are dying. Using street drugs is dangerous and immoral or wrong. People can't take people's rights away on the very other side, and the status quo can't continue. I agree, the status quo shouldn't continue. The problem with emotional or immoral arguments is that once people get on this, they're pretty unshakable as far as their view goes. And even if you present people with evidence, that they do not shift around that. Um, it's usually based on this appeal to emotions fallacy around it. And then you get this prompt to very short-term reactive solutions, which are often, as Mencken was quoted as, for every complex problem, that there's a solution which is, quick, easy, and frankly wrong, because it doesn't take into account the complexity. This is where a whole bunch of safe supply kind of argument came from. And this is a little bit where the involuntary treatment argument is coming from, that it's unfortunately bad policy tends to precede evidence, and it's based on this sort of reactivity, as opposed to good policy follows clear-cut evidence around it. So I think, in general, to avoid falling into that trap, it's always important to consider evidence. Think about, remember that substance use disorders addiction is a chronic condition, not a short-term one. And then what would be the outcome if the policy is enacted? Because that helps kind of problem solve as to, okay, what difficulties are gonna come up with its invocation. So some of the extrapolations that come out of the idea of involuntary treatment is that, well, addiction treatment is beneficial for those who seek voluntary treatment, so it must be equally as beneficial for those who are thrown into it involuntarily, or potentially even more so. Not necessarily the case. There isn't really evidence to support that. Um, and then because there's a neurobiological basis to the substance use disorders, then all of a sudden there's this implication that, well, because a person has a substance use disorder and it's neurobiologically based, therefore they can't make a treatment decision on their own, so they lack capacity, and because it's a brain disease. Um, I remember way back when Alan Leichner was the head of NIDA, that Nora Volkoff is these days, and they had an ad campaign way back, which was, addiction is a brain disease, and to try and destigmatize. And a lot of people showed up for treatment, but they said, "Well, I got a brain disease, fix me." And then they had to change because it was ineffective. They had to change the approach to say, well, addiction is a brain disease, but it's not just a brain disease, that there's a behavior which is associated with it as well. And I think the real problems with involuntary treatment, and we'll go through it more, is that capacity can change rapidly depending on intoxication and withdrawal state. We really don't have a lot of pharmacologic treatments for the substance use disorders. We only have one long-acting injectable, which is the Sublocade, the buprenorphine long-acting version. And that treatment really requires engagement and motivation and intact cognitive abilities. Whereas if you're going to take people who are more severe, that have greater likelihood of having more cognitive capacity issues, and then an acute short-term solution for chronic relapsing illness doesn't make a lot of logical sense. All my work in psychiatry, but particularly in addiction, is spent in engagement and helping to try and persuade people to change what they're doing. Because the majority of people that I'm seeing are either pre-contemplative or contemplative around change. I would love it if people are in preparation and action all the time. That's easy because then they engage in treatment and so on, or if they're in maintenance around it. But this is the majority of our work. And the idea of like somebody is thrust into a treatment against their will isn't going to make their stage of change suddenly change to being in preparation or action. They're still going to be here, And this requires people, it requires time and trust. And then persuasion, again, requires a lot of trust to be able to help work with the person to see if they'll actually shift in their approach to matters. There probably is a role for involuntary care in certain circumstances. So I don't think a lot of people would kind of argue against the idea of short-term involuntary hospital care. So holding a person, for a brief period of time to evaluate, to come up with a treatment plan, to initiate some sort of treatment, to try and engage, and to reassess, I think is a very reasonable thing. It's observant of people's rights. It focuses on immediate safety, um, and that the difficulty, though, is our emergencies are overwhelmed. And then if we try to use something like the Mental Health Act, our psychiatric beds are 100% of the time over capacity. And so they can't get admitted. And so they'll often get discharged from the emergency. And then even if they did get admitted to the psychiatric ward, you don't get psychiatric care, or you get psychiatric care. You don't get addiction care on the psychiatric ward. They're not really designed for that. Dealing with psychosis and suicidality, you might get a consult to addiction medicine, but as far as actual treatment there often isn't any available. The other group that you wonder about is these people with acquired brain injury. Um, they might have chronic sort of capacity issues. The difficulty is, I don't know of any particularly good treatment. Um, and so maybe a period of absence might be the best sort of option with it, but it's a real balance of trying to, you know, it, will they benefit from care, this group or not? And then are you going to be into a situation where you're potentially warehousing people against their will, which I have difficulty with. People sometimes conflate involuntary care with coercive care. Drug courts are a classic example of coercive care. Um, so people get charged with an offense, and they're given the opportunity to go through the drug treatment route around it. Humane, helps sort of address problems that are contributing to criminality. Choice is maintained, and there is data that there is some effectiveness to it. Likely, this should be expanded, and it would require potentially even sort of more bylaws of cities to be updated, so that way there could be a mechanism to help direct people towards drug courts. So let's think about what is the evidence for involuntary treatment for substance use disorders? We wrote a paper published in the Canadian Journal, but the big sort of systematic review was Anis Baji did it also in the Canadian Journal, expanded on the WERB article, which was back in 2016, which had limited numbers of trials that were involved in it. The Dr. Baji's one tended to expand it and look at more around it. What you find from the literature is that there's no Canadian data. So all the data comes from the US, Europe, or Australia in general. There's some from in some of the Asian areas, but mostly it's tied to criminality, and there's no real treatment, which is often provided. And so the ones better to look at are probably Europe and Australia, as well as the US around it. One of the big findings is that voluntary treatment consistently outperforms involuntary treatment. It's not to say that people don't improve with involuntary treatment. Some do. Um, the difficulty is that the group isn't really well characterized, um, and that often they have longer stays, and they require extensive specialized treatment resources. to see some sort of benefit there. The key predictor of outcome, generally though, is severity of the substance use disorder. The more severe the substance use disorder, the less likely a person is to respond to treatment. The data for involuntary care that comes from both the criminal justice system in the US, as well as when you look at other sort of jurisdictions, is that people do stay in residential treatment and complete treatment more often when they're subject to involuntary care. And normally, for voluntary people, that would lead to better outcomes. What's curious is that despite people completing treatment, finishing treatment more often, is that the outcomes rapidly go back to people who weren't in treatment again. Um, the other thing which comes out is that they don't evaluate future treatment seeking in any of the studies. Most of the studies are low quality. They tend to not describe what sort of treatment was provided. A lot of them exclude opioid use disorders and stimulant use disorders. So almost all of the data comes from alcohol and cannabis. What's fascinating is also in Europe and Australia, they don't have fentanyl. At some point, they're going to have fentanyl, but it's still they're dealing with heroin just because of the access points for it are still sort of there. Um, and so most of the involuntary data looks at alcohol and cannabis and isn't really applicable to the Canadian scene where the drugs that we have an issue with predominantly are fentanyl and methamphetamine. So it's difficult to extrapolate from that sort of data. You can't talk about addiction treatment without talking about Portugal. Portugal, it's interesting how people have spun the evidence around it. Portugal made drug consumption possession, they decriminalized it, but they didn't legalize it. And if police see people using, they seize the drug, they come over, they take the drug, and then they're directed to the dissuasion commission. Um, a lot of money for this, and they got bilateral support from both more left-wing parties, right-wing parties. They all came together and have maintained their support of it. But a lot of the policing and money that used to go to policing went to treatment and got redirected. That's not going to happen in North America, but that's what happened in Portugal around it. And they really focused on harm reduction and expanding treatment services, doing a lot of street outreach, making sure people are on opioid agonist therapy. And so the assessments that people got in Portugal tended to focus on social reintegration as the priority. Portugal's a different society than Canada in that we're talking about multi-generational families that are integrated. There's much more of an acceptance of societal sort of goals as opposed to uniqueness and independence and freedom. And they can do things in Portugal that you can't in North America. So, like the commission, when they're sort of coercing people to try and enter treatment, because there is no involuntary treatment in Portugal, it is coercive, and that's what the role of the commission is. Coercive is they can impose fines, they can impose community services, they can ban people from places, they can take their license away, take away their passport, cut off subsidies, but they can also remove property from the home. And so there's high motivation from families for to say, well, rather than us losing sort of some of these things, this person's got to go to treatment around it. So there's real motivation. And then the other thing which they did in Portugal is that they said addiction is a problem that everyone in our society needs to deal with. And so all physicians, nurses, and psychology ended up having to get training in addiction, which certainly isn't the case in North America. One of the big findings from studies to date is that after involuntary treatment, people have a higher risk of overdose. That's been found in Sweden as well as it was found in the Norwegian involuntary treatment studies. Massachusetts has involuntary treatment, and they even provide OAT. One of the fascinating things with the Section 35 data, this is the um, blocking on the term for what it's called in Massachusetts. It'll come to me in a bit. But the majority of the people who are subject to involuntary treatment are women, totally out of keeping with the data when it comes to substance use. My suspicion around this is that men get criminally charged and go to jail, and the women end up going to treatment instead, and that's probably why there's the difference there. But they certainly noticed that with involuntary treatment that there was decreased ER utilization and rehospitalization. They were more likely to go into bed-based care afterwards, more likely to be started on buprenorphine or naltrexone. They got long-acting naltrexone in the US that we don't have, but less likelihood of getting methadone. The problem is that both groups, whether they were involuntary or voluntary, few people actually took OAT after they left treatment. Only 40% around it. But there definitely was an increased non-fatal overdoses as well as that in deaths. Both these data is non-significant around it, but it's because when you have relatively infrequent phenomena, that it's tough to get statistical significance around it. But again, it sort of confirms that, overdose is something that happens after involuntary care. One of the big issues is that, okay, we're talking about involuntary care, but most people who want treatment can't even get it. Less than 10% of people are able to sort of, seek treatment. And then when they want to seek treatment, what they do tend to get is non-evidence-based care, where there's a lack of sort of medical or psychiatric care, which is involved. They get some sort of generic group therapy, which is mostly 12-step in focus. Alberta is unique in provinces in that at least that there's some legislation around. There's requirements in for addiction treatment as to what like a service would provide, but it's only upon reporting for critical incidents. There isn't sort of a mandate as to you have to provide evidence-based treatment, so people can still be blindfolded and put on a horse and call that that's some sort of addiction treatment. The majority of treatment remains quite brief, 21 days often, or less. Even though the Alberta government has really done a great job at expanding availability of bed-based treatment and making it free, people still have to pay their rents or their mortgages, and they can't be working, obviously, when they're in some sort of bed-based care. So the affordability issue remains something which is still there. And then when people leave inpatient or bed-based care, there's usually no aftercare. They're told to go to a church basement for a 12-step meeting. And so this was, Jill Diamond ended up, her family lost their brother, and who was a addiction counselor, and who had problems with addiction. And here's a guy who knew the system, knew how to sort of access care, and even he couldn't around it. And so expanding sort of care seems to be critical. This is, one of the huge concerns is re-traumatization, re-victimization. I recognize as a white male in the health who works in the healthcare system, I view the hospital as safe. My dad was a physician. I would go to the University of Alberta Hospital doctor's lounge on Saturday mornings when my dad was doing rounds as a kid, and I came to view the hospital as a safe place. Our patients don't. They don't view hospital as safe or as treatment necessarily as safe around it. And so that's one of the concerns. And then the data seems to suggest that when you subject people to the Mental Health Act, community treatment orders, or involuntary treatment, it tends to over-identify people who are Indigenous from minorities or immigrant populations. It's led to in northern Australia, the out of Darwin, there was an addiction mandatory involuntary treatment, and almost all the people who were picked up by it were Indigenous, and eventually led to the program being shut down. So super high risk, considering that we think about 50% of the overdoses in Calgary are people, who have an Indigenous backgrounds, and 75% of the homeless population in Edmonton is Indigenous. So this might be the group that inadvertently gets sort of picked up. So it really, I worry about it running counter to trauma-informed care. So, you could use the Mental Health Act. I think the problem is that we don't have any psychiatric beds. The system's been underfunded for decades, and so they can't get into there. Um, you could potentially use a community treatment order, but to do that, they have to be hospitalized for more than 30 days on an involuntary basis. And then you would have to sort of demonstrate that a CTO is beneficial for the treatment of addiction. Hasn't really been used for that. I see some people write in, must attend addiction counseling. You can't, that doesn't happen. The only thing that I find that happens with CTOs is that I know when a person's gotten their injection. And that's it. I can't mandate oral meds. I can't, you can try and have people come into the home to do med monitoring, but even that is super challenging around it. So CTOs probably aren't a great option. So I think that's part of the reason why they're looking at this legislation. Um, the difficulty is that it seems to focus on a particular condition like a substance use disorder rather than risk and likelihood of the risk that the person has, as well as the likelihood of them benefiting. And as you'll see, the description of severity is really challenging, even in the legislation. And so, is it based on overdose, treatment failures, eye of the beholder? Who knows? If it is for the most severe, they're going to have the lowest recovery capital, highest level of cognitive deficits, least likelihood to respond to treatment, highest rates of comorbidities, medical and psychiatric, and going to have the most complicated and severe withdrawals. Um, so we'll talk a little bit about what is imminent risk. The legislation also doesn't really talk about which addictions per se. It's just addiction in general, or substance use in general, when really probably the stimulants and opioids are the main thing that we're sort of focused on. And then it's this duration, is that although the Datto study from Daly is the one that often gets quoted as being like, it takes 90 days or 3 months for people to change behavior. Most of it's outpatient, and that's with voluntary populations. We're not clear about, involuntary. This is kind of what I've already talked about is, one of the key things I think is with involuntary care is, okay, if we don't have a lot of treatments for it, we just got the subcutaneous buprenorphine, then our only other real treatment is therapy. Forced psychotherapy has not been shown to be beneficial. Mandated AA treatment has also not been shown to be beneficial. And if that's our primary modality that we're going to be using, that's a bit of a problem. And then tons of our agents, we got an agent for opioids, but we don't have it for the majority of our other substance use disorders, particularly stimulants. So let's look at Bill 53. So an apprehension order, can be, and I'm going to focus on adults and not on youth. Youth probably is where compassionate intervention is going to be utilized first. They've delayed the rollout of CI for adults by probably about a year. I think as they're trying to sort through what to do with it, whereas youth, you already have the PCHAD orders, which are there, and it might actually sort of enhance medical care to the PCHAD, which was basically a social detox before. But I'm going to be talking about the adults, but the whole kind of youth thing is another discussion. So an adult has to demonstrate one of two things, either substantial harm to themselves or substantial harm to others. And so the first part talks about the self-harm. They have to have just one or more of the following. And then there's like they have to have a certain severity of substance use or addiction. This is not defined. They have to have an overdose history or frequent interaction with EMTs or the ER. Again, what qualifies as frequent? Not clear. They have to have substantial mental or physical deterioration secondary to their substance use. All these are or, they're not ands, by the way. Diminished ability, previously at a CI facility, negative effect in key areas of life due to their substance use, high risk behavior, any other relevant factor. This is 100% of the people that I see. So I'm a little bit left with what is, what actually is going to meet the criteria for an apprehension. The other side of it is likely to cause harm to others. Again, it's based on the severity of their substance use. Again, not defined. It's not defined based on DSM-5 criteria or other sort of definitions of addiction. And then this neglecting or unable to care for a dependent secondary to substance use, harming a dependent secondary to substance use, negative impacting community safety or other relevant factors. Again, these things are really ill-defined, and I think that we're going to have a tough time figuring out what is the threshold for it. And the severity definition is severe intoxication or impairment secondary to use, poorly controlled or unstable medical status because of it, or inability to meet daily needs of living. Again, very much an eye of a beholder thing. So an application can be made based on these vague thresholds by either family, a care provider, or the police. And care providers are defined as being either a nurse, a physician, a psychologist, a paramedic, and all these people have to be regulated members of their colleges or an addiction counselor. Social worker can't be there, which is kind of interesting for some reason. So I don't know how they came up with that around it, but I think it's really clear that, I know family members who are talking about that they want to apply to have a family member sort of committed under this. They don't really know what the thresholds are, and so it needs to be written out in advance. That way, people know exactly what the threshold is. It'll help us as care providers as well. Once they get sort of apprehended. So if the commission lawyer, reviews the application, so there's one person who reviews it, and then if they approve it, then PACT through the police end up conveying the person to a facility. They're detained for 72 hours, and then they're informed of their rights. The commission, which consists of lawyer, public person, and a physician, typically of an addiction background, addiction treatment background, they can either dismiss, they can issue and terminate apprehension, they can do a whole bunch of different things as far as the act goes. Within 72 hours, the person has to be assessed, but they can also be treated, and they use the term control around it, because I would imagine that you would have a certain amount of agitation that's going to happen. So a report is prepared, not clear on who is going to do this report, but it talks about substance use and addiction assessment, likelihood of causing harm to self or others, and then puts together treatment recommendations. Capacity doesn't seem to be part of it. At least the way the act is written. There is some reference to capacity at some point in the act, but as far as regular assessments, that needs to be a component which is there. They talk about immediate stabilization and medical needs to be addressed. Not clear about whether the mental health needs are being addressed with that, because it seems on stabilization and medical needs. And then a care planning hearing involving the commission occurs with these sort of people. And so they decide whether to say, no, there's no reason to hold, you can let the person go. They can be held in a secure treatment setting, so an inpatient bed-based setting, which is one of the CI sites, the planned CI sites of 150 beds, either in Edmonton or in Calgary, for up to 3 months that's renewable, or in a bed-based community situation. Not sure how they're going to do this, but that's what's in the act and how they decide that. Or it can be non-bed based, so a pure outpatient clinic. And then apparently the care plan gets reviewed every 6 weeks, but the person may request a review prior to that and is to be seen within 7 days. Um, I sit on the mental health review panels, and they are independent bodies. They're objective, independent bodies that are there for the patient. Um, and it holds the treatment team to task around it. The people, if they appeal, are appealing to the commission, who are also the people who are mandating their treatment. So they're not independent in that regard. So that sounds problematic. And I'm guessing that there'll be a legal challenge around that. It's unclear if they can appeal to the Court of Queen's Bench. Unlikely that these timeframes are going to be possible. Even trying to set up mental health review panels for people who are admitted under the Mental Health Act, really hard to get it within 7 days, and then have to review the care plan repeatedly every 6 weeks. I, I don't think is going to be possible. There's an inability to refuse certain aspects of care. So they can't refuse observation, monitoring, or assessment. They can't refuse clinical advice. I'm not really clear how this could be done. Here's maybe a suggestion of what they could do it, but this would be my response is that, so it's funny. This is in the act. I don't think it's, I don't think it's reasonable. The one which is worrisome is that Schedule 1 drugs to treat substance use disorders can be administered without consent. And the risk is that potentially people would get cold starts on LAI buprenorphine, which is interesting that I'm not sure. Again, I think this is going to be subject to a legal challenge, particularly if a person has capacity. And that's why I think it's so critical that there needs to be a capacity assessment. So I expect there'll be a legal challenge to the legislation based on that. If a person doesn't have capacity, there has to be a substitute decision maker. Is there going to be something equivalent to a Form 11? Form 11 is applicable to the Mental Health Act, Form 1s and Form 2, but not necessarily to CI. There's a weird component of the legislation where they go at great length to describe how there's no legal responsibility from anyone from government to even the treatment providers. I'm not sure why you would bake that into legislation, um, unless you're thinking that people are going to be holding people liable, which kind of suggests that maybe there's some problems with it. But I expect that will also get a challenge, and then privacy will also be a source of challenge. So the commission can compel information, which is potentially confidential health information. So these are the three areas that I think likely there's going to be a legal challenge that'll come up. The other things that it'll come up is these compassionate intervention sites are not going to be like bed-based treatment. They need to be like a forensic inpatient unit where you have high observation areas. You got to have security sort of present. You're going to have all the medical supports which are there because people are going to be in significant withdrawal. There's going to be lots of complicated sort of issues, and you're going to need a highly skilled sort of workforce to work in this. And I'm not sure who are going to be wanting to work in that setting. I have no idea how they're going to implement this in community or rural settings. You can see maybe in an urban, but in the community, so when a person, how do you mandate a person staying in a bed-based treatment, which is not a secure facility? People will leave, and then sort of the police can be contacted. I think the police are going to revolt if they're being contacted all the time for people who have breached their CI. sort of mandate around it. And then, I think a lot of the emerge docs have rightfully worried. It's like, okay, well, if a person needs medical care beyond that of the CI facility, they're going to show up in the emergency. But then do you send them back, particularly if from a moral or ethical view that you're doubting that? And then what is your liability if you don't? Um, these are all completely unknown, and I would not want to be the person who is subject to the test case around it. And then what do you do with the people who have acquired brain injury? Um, their likelihood of benefit is probably limited. So prior to CI, I think probably what a much more rational approach to matters would be, you know, there needs to be appropriate funding for psychiatric and addiction care in the province of Alberta. We need to expand access to voluntary treatment, and the Alberta government has been doing that. But we also need to expand outpatient care. We've got adult addiction services. We got one in Calgary for a city of 1.6 million. There needs to be multiple ones of these in different sort of quadrants to make it accessible. All of medicine does need to step up, and also nursing, as well as psychology, as well as anybody who's working um, in medical related fields. We have to have training as part of all of for all of our residents um, on substance use, and people need to be able to integrate care and be able to do it competently. We probably need short stay units. Um, with teams who have extensive addiction and medical psychiatric skill sets, as well as social work support. So we have one short stay unit for Calgary, and having more that particularly have a focus for substance use might be a wise investment. Um, any kind of bed-based treatment needs to have structured aftercare. It doesn't exist currently. And this has to be in place before CI goes forward. And probably that aftercare involves dedicated ACT teams. There's two ACT teams for the province of Alberta, one in Edmonton, one in Calgary. That's insufficient for Calgary. The estimates are that there needs to be 10 to 16 ACT teams, just for mental health related issues. If you add on the substance use, we're talking about even more. I think there does need to be increased use of the drug courts to help with the sort of treatment, and there needs to be these other components. So I think if involuntary treatment is to be used, it needs to be as brief as humanly possible. Um, the least restrictive treatment setting needs to be used. It should be reserved as a last resort, only for people who have consistently refused treatment or failed multiple prior adequate attempts. There needs to be a clear-cut threshold as to what is, merits involuntary treatment. It has to be medically managed. This is the issue that they're going to run into in Manitoba, is that if you try and just sort of put people in a non-medical facility, it's going to be a disaster as far as potential withdrawal goes. And so they need to have like the full gamut of medical availability, medically available treatment. Capacity needs to be evaluated on an ongoing basis, not only when they first come in, but continually to make sure that people's sort of rights are being maintained, that they have ability and they have the ability to appeal. And the appeal has to be to an objective third party who is there for the patient and not necessarily for the institution. The involuntary treatment has to be rigorously evaluated by an objective third party. I don't think the government can be the people who evaluate it. And even though core is meant to be somewhat sort of removed, it is really part of the government. It needs to be an outside sort of source that's that evaluating it. Maybe something for CRISM to wonder about. Um, it also shouldn't come at the expense of expanding resources for people who want or need treatment. The worry is that a whole bunch of funding is going to go to CI, and it's going to come at the price of expanding other sort of care. Um, and then it really needs to safeguard against inadvertently harming those people who are Indigenous minorities, marginalized people who are vulnerable around it. So I think the key takeaways, we'll go to questions, is really limited evidence to support involuntary treatment for substance use disorders, and that which exists is low quality and minimal applicability to Canada. The continuum of voluntary care from harm reduction to more recovery-based options, everything in between needs to be expanded. And if it is to be used, it needs to be of last resort with clear guidance on thresholds. And then there has to be established structured aftercare in place prior to its implementation. And I'll leave it at that. Thanks.
Okay, Dave, thanks so much. That was a great talk and very comprehensive on a really complex but very relevant topic at the moment. And I there are a few questions, and I'm going to filter them out to you.
Okay.
And someone that also practices in addictions and forensics, and actually, I work for the drug court here in Edmonton, so it was really great to hear some of those perspectives that you had. You know, Dave, like you addressed, like we feel the pressure to do something because we see the data, the numbers, and you talked about your own example of walking through the streets of Vancouver and seeing some of the difficulties. So, what, like you've talked about a pathway, like if the Compassion Care Act does come out, like you talked about capacity, it needs to be part of that, and
Yeah.
maybe short stays, maybe step down to more programs like drug court. Where do you like how do you, I guess, when you're speaking to someone that's talking about compassion care or a family member or patient that says like, I've my loved one has overdosed multiple times, and they come to the emergency room, and then they're sort of like go, versus on the mental health side of things, we know that if someone was coming in maybe for like self-harm or suicidal thoughts, we might approach that a little differently. Like, do you see a more compelling argument in certain cases than others for compassion care, like that population that you're talking about, maybe in extreme cases?
Yep. And I would agree, right? And whether it has to be, under the Compassionate Intervention Act, or whether you can actually just adequately use the Mental Health Act. The Mental Health Act that, I mean, the JH ruling that sort of was the one that, if people don't know, it's somebody was held at the Foothills Hospital on a medical ward based on their sort of severe substance use and their risk of potential relapse, and they were basically warehoused.
Mhm.
And the courts said this is this is inappropriate. Not that substance use is not sort of a reason to use the Mental Health Act. It's just that you need to use the Mental Health Act to for treatment. It can't
Mhm.
be just for simply warehousing a person. And so the Mental Health Act is really sort of focused on risk, and a person has to have a potential of benefit around it. And so when a person's at acute imminent risk, and we all work with people where there's times where it's like, okay, like, I mean, I'm really worried about what's going to happen with them. You would think that that would be appropriate. And then, but the problem is there needs to be a place where they can be directed towards care. And so we don't have
Mhm.
inpatient addiction-based care, which is attached to the medical system.
Yeah.
And
Yeah.
so if that was present, then there would be a chance for sort of evaluation, a treatment to be initiated of some kind, and then hopefully in the least restrictive setting sought out where you can have connections to outpatient, either bed-based care or outpatient, pure
Yeah.
outpatient care.
And we're getting some questions about, thanks for that answer, Dave. Very,
Yeah.
makes a lot of sense to me. Do you know what kind of success they're having in other provinces, like for instance, specifically BC, like the Redfish Enhanced Care Unit, and then similarly, what about PCHAD here? You talked about youth. Do you know, could you speak to some of that data?
Yeah, the so Redfish, the data is gradually accumulating. Um, it's preliminary, and so there is some benefit, but everybody who's being held at Redfish has a severe and persistent mental illness, typically schizophrenia, as well as a major substance use disorder. There's some exceptions of people who have a serious violence history. There's some people with other mental illness, but they all have to have a major psychiatric sort of disorder present. They can't be held just on substance use alone.
Mm,
The problem that they're running into, which you hear from a lot of different treatment programs is these people with acquired brain injury, either from overdoses or whether fetal alcohol exposure prior to it, or the, the cognitive capacity is really low, that it's hard to do treatment. And then they're left with this issue of, so Redfish has had to develop a number of sort of long-term housing options for people who are that are, out near the center, um, because there's no place for them to go, and they
mm,
remain sort of unwell. And a lot of times when they leave Redfish, they go back to the downtown east side, and it's back to, prior behavior almost instantaneously around it.
mm,
So that one's the hard one. PCHAD, there's very little published evidence around it. The only studies which I've seen published have been mostly the sort of looking at families' kind of experiences with PCHAD afterwards, and a lot of them were relieved with having. It's like, okay, they're somewhere, but then disappointed at the outcomes because it went back to sort of business as usual around it. I do think youth is a different population, that there's, often things are earlier in the course. There's a chance for a reset around it. And I think if PCHAD did have more kind of treatment, which was attached to it, as opposed to just sort of a social detoxification, um, and there was connections to outpatient treatment afterwards, that would potentially have a bit more of a role. I get it. Like, I mean, if say one of my family members was really ill, I mean, I would be looking at different sort of options, and having the fear of getting the phone call that they're dead.
mm.
Um, and so I understand where families would be coming from, and where, the government is sort of, trying to do something around it. And the question is, I think it needs a bit more nuance than the way that it's being put forward.
Yeah. So, they really appreciate that. We're getting a ton of questions that I don't think we'll be able to get to all of them, but I think the last word I'll leave it to you is there a place where people can go, like a good resource or reference that you'd recommend, whether it's review. I know you've been involved with a lot of publications in this area as well that people could look at.
Yeah, I mean, probably Dr. Baji's review is likely the best, which was in the Canadian Journal of Addiction. Um, there's a number of articles which have come out. There was another systematic review. I can't remember which journal it was published in, as well. That I think, looking at the evidence, I think unfortunately when you look at the evidence, it's not very good. Um, you can look at the Compassionate Intervention Act. It's easy just to look up Bill 53. If you Google it, that you can find it and read through it. Um, I'm hoping that if, it's already been passed, but I'm hoping that they'll make substantial tweaks to it. I do have a certain amount of confidence that, Rob Tanguay is kind of in charge of it. He's a smart guy, and I think that he's heard the concerns, and is working to try and say, okay, how are we going to manage this? Um, before it comes out. But I really think that, yeah, if there was sort of published thresholds that families could kind of understand, as well as like caregivers, I think it would be really good for us.
Really, really appreciate your time today. Thanks so much, Dave, Dr. Crockford. And Thanks everyone for tuning in. And if you have any questions, you can leave them with me through our CRISM website. This will be posted up on the CRISM website, and then I can try to filter them to Dave and get you your answer back. But really appreciate your time again, and thanks everyone for tuning in. Yeah. Take care.
Thanks. Have a good afternoon.